get started in just a minute. We're letting everyone filter in. Alrighty, looks like we have just about everyone for today. So hi everyone, my name is Julia Mayetta. We are so pleased that you all could join us for this week's lecture in our 12-week No Neuropsychology Didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities for trainees across the world. We would like to thank our sponsors for their financial support of this series. And before we get started, here are the disclaimers for our series. So this training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box in the lower left-hand corner of your screen. And today's lecture will be recorded and will be provided on our website later this week. Now it is my pleasure to introduce Dr. Alice-Ann Holland for today's lecture on pediatric brain tumors. Dr. Holland is an associate professor in psychiatry at UT Southwestern Medical Center and research director of the Neuropsychology Service at Children's Medical Center, Dallas, where she also conducts clinical neuropsychological evaluations of medically complex children and adolescents, specializing in cancer and rare brain diseases. Dr. Holland served as president of the Texas Psychological Association in 2019. She currently serves on the boards for the National Academy of Neuropsychology and the Federation of Associations in Behavioral and Brain Sciences. She has been the recipient of numerous awards from organizations including the American Psychological Association, American Board of Professional Psychology, American Academy of Clinical Neuropsychology, National Academy of Neuropsychology, National Register of Health Service Providers in Psychology, Texas Psychological Association, and the Dallas Psychological Association. So we are certainly very pleased to have Dr. Holland with us here today. So I'll stop sharing my screen and let Dr. Holland take it away.
Thanks so much, Julia. Let me get this pulled up real quick. Okay, is that working?
Yes, looks good.
Great. All right. Well, thank you guys for having me, and I am going to try to present what can be a somewhat complex topic, just sort of at a quick introductory level, sort of intended for a broad overview of specifically focusing on the two most common pediatric brain tumors, which are Medulloblastoma and Pilocytic Astrocytoma. But before we jump into that, let me just hang on. Okay. Let me tell you kind of where we're going here. I'm going to start by just kind of going over pediatric cancer in general and then jump into brain tumors. We'll talk about some acute considerations, during the cancer treatment process, and then neurocognitive late effects. And if we have time, I'll talk about some research that we've been doing. Just keep an eye on the clock here and see what we can get done. So pediatric cancers, they are in some ways similar, but in many ways very different from adult cancers. So in the pediatric and adolescent young adult population, the risk factors tend to be early life, DNA mutations, and other more genetic factors such as Down syndrome, which actually carries a 20 times increased risk for leukemia. And the pediatric populations also tend to have better response rates to chemo. Their bodies tolerate the effects better. So in many ways, although it's difficult to see a child go through cancer treatment, they often have a fairly good prognosis in a lot of ways. By age group, the most common cancers in pediatrics are leukemia and brain tumors from 0 to 14. In fact, the average age of diagnosis of a brain tumor is age 5. Then into the adolescent period, you start seeing more lymphomas, thyroid cancers, still brain tumors, and then gets into more adult cancers like breast cancer after about age 20. The pediatric cancer is actually the second most common cause of death in the pediatric population. The first is accidents. So it's actually the leading cause of death in terms of medical causes. However, the mean survival rate is generally above 80%, and we'll talk more about specific diagnoses and their survival rates. So what that means is that we have a lot of survivors, and we have a lot of kids dealing with cognitively effects of the treatment that they've been through. So we'll jump into that in a minute here. I'm going to talk about first, we often think of, when we think of pediatric cancer, we think of leukemia. Brain tumors actually aren't that far behind in terms of the frequency with which we see them in the pediatric population. And these are just some slides showing data regarding survival rates. The leukemia survival rates are very strong. Brain tumors are not that far behind. This chart shows brain and CNS tumors being around 75%. This is somewhat dated. It's actually gone up a little bit even since that time. And that really reflects the amazing research advances in terms of treatment and treatment protocols that we have seen in the last, certainly the last several decades, even the last decade and ongoing. So, following this trend, we're seeing declines in mortality rates across the board, which is really good. You'll see that dark black line is the brain tumor line. So it's obviously a little bit more of a high mortality rate than some of the other cancers, but still we're making progress in that area as well. So that's been very encouraging. So in terms of survival rates, there's certain ways to talk about an individual's prognosis. Diagnosis is just one of them. One thing I want to touch on is ethnicity. This is current data. This chart shows not a historical trend, but looking at a certain time point, how many years after diagnosis, and what percentage are surviving. And this is all cancers combined. This is NIH data. And you see from the chart that white non-Hispanics are down. They're significantly lower than the white non-Hispanics and even the other ethnicities listed in this chart. And one thing, so research has kind of tried to look into that to see what's causing this pattern. This is not just, it's a trend we see in pediatrics, but it's also a trend we see in all age groups and all cancers. And really what the data has shown really due to socioeconomic status, insurance barriers, and access to care issues, which is really unfortunate. It's not about the cancer itself. It's not about response to treatment. So that's something to, I share that just because I think we all should be aware of that and, should advocate for what we can do to help these patients get better access to care for neuropsychology, but for all aspects of the cancer situation, the cancer experience.
Dr. Holland, I'm so sorry to interrupt. It sounds like your audio is going in and out a little bit. It sounds like a pinging in the background. I don't know if maybe there's email interference or. Can you hear me?
All right, how's that? Is that better?
Oh, that's much better. Okay.
Great.
Perfect.
Okay.
Thank you.
So sorry.
No, that's okay.
Yeah, okay. So where were we? So talking about barriers to care, we did some research at Children's Health to look at factors specifically in our brain tumor population. And we looked at data from 2017 to 2019 regarding patients that were referred to neuropsychology. We wanted to see what percentage came and showed up for their appointments versus who didn't come. And what we found is that, first of all, physical distance, so living far away, but being non-English speaking, or being older at diagnosis were some factors that frequently resulted in children not coming to their neuropsychology appointment. We had a few that actually just refused to schedule, some that scheduled and no-showed, but those were the trends that we saw. And interestingly, if we break it up by diagnosis, for medulloblastoma, many more in terms of percentage-wise. We had a much higher percentage who actually showed up for testing. As opposed to low-grade glioma, which includes pilocytic astrocytoma, about 50% showed up and others did not. And one theory we have for this is that medulloblastoma is a much more aggressive tumor, and the prognosis is a little bit more grim in terms of just medical prognosis. And so we feel like these families maybe get a slightly different message in terms of what we're telling them and what they need to do and follow up. So this information gave us some good data in terms of how to improve our messaging in clinic, how to improve our triage for neuropsychology, things like that. So all of that is just kind of context for the broader picture of pediatric cancer and some factors that relate to survival and also to follow up. But I'm going to jump into brain tumors now. Let me see. And we're going to talk about some important terms when we're talking about brain tumors. So most of brain tumors in pediatric cancer in the pediatric population are 60 to 70% of them are infratentorial, which means that they are below the tentorium. And the tentorium you see there in that image, it's part of the dura mater that covers the upper surface of the cerebellum. And it essentially divides the posterior fossa, which is this, posterior being back, fossa being bone, the backbone region of the brain. It divides it from the rest of the cranial vault. So the majority of the tumors we see in kids occur in that region of the brain. So that's one thing to know. You'll see that term a lot when you're working with this population. Some other terms. So anaplastic is a term that you'll see sometimes, which refers to poor cellular differentiation. Essentially, it's kind of a messy tumor. It looks messy. That image is actually an anaplastic ependymoma. And as a result of it being kind of messy and poorly differentiated, it ends up being harder to treat, harder to resect, harder to basically get it all. So anaplastic is always a higher risk tumor. And then degrees of resection is also important to kind of understand these terms. So gross total is what you'll see surgeons refer to as we got it all out. It actually doesn't always mean that they got it all out, but it means that about 99% was removed. Near total is 91 to 98%. Subtotal is 50 to 90%, and then partial is less than 50%. And what you see being the most common factor in terms of how much they can remove is the location of the tumor. Oftentimes, the tumor being in the back of the brain can be invasive into the brainstem. And so if that happens, obviously there's parts that you just can't risk taking out. So here's an image that shows gross total versus near total versus subtotal. And basically the white gross total, you really don't see anything. The white dots and sort of the blurry white spot in those other two images show residual tumor. And so that gives you kind of a visual of what we're talking about when we're talking about these terms. So another way to talk about brain tumors is looking at pathology. So many brain tumors arise from glial cells, and the most common are the astrocytomas, ependymomas, and oligodendrogliomas. Arising from neuronal cells, we have medulloblastomas and a tumor called PNET, which is primitive neuroectodermal tumor. And that's actually the image that you see there. PNETs and medulloblastomas used to be sort of clumped as one category. And currently, we don't really view them as similar at all. We very much make a distinction. So you'll see, and if you're reading older research, you'll often see medullo and PNET lumped together. In more recent research, you'll see those separated out. So I've referenced medulloblastoma a bunch. What is this exactly? It's the most common malignant pediatric brain tumor, as I mentioned, formerly associated with PNETs, and it's thought to arise from cerebellar stem cells. So hence, you often see it in the posterior fossa region of the brain. That is not necessarily always the case. Sometimes those cells, the cancer cells, can migrate into the cerebrum. So you occasionally do get tumors, medulloblastoma and pilocytic astrocytoma, that are in the main cerebrum area of the brain. However, typically originates still from the cerebellar region. So pilocytic astrocytoma is the other brain tumor that's fairly common in pediatrics. And it's the most common benign pediatric brain tumor. So benign being, non-aggressive, non-invasive, but obviously any tumor in the brain is going to be a problem because it's taking up space and causing mass effect, pressure. The bigger it is, the worse it is, obviously. So these tumors, both these types of tumors and brain tumors in general, often first get diagnosed when kids start having symptoms of mass effect, such as nausea, vomiting, balance issues, things like that. So pilocytic astrocytoma is actually a type of glioma, so it's a glial cell tumor. And specifically, it arises from astrocytes, as you might expect from the name. So these two tumors are, they're very different, but they're also very commonly located in the same area, and that's in that posterior fossa area of the brain. So as a result, they form a nice comparison group between the two diagnoses. Medulloblastoma is typically treated with, they both are treated with surgical resection. Medulloblastoma, you'll also get chemo and radiation. Pilocytic astrocytoma almost never gets radiation. So it can be in that way, sort of a control for what are the effects of radiation in particular. In terms of severities, the World Health Organization grading, grades 1 to 4 are sometimes used, not always used. Really what we're using more these days are pathogenesis classifications and genotyping. So in terms of pathogenesis, an example of that is in medulloblastoma. And this really has come out of research done in the last 10, 15 years that we've really kind of categorized medulloblastoma based on their cellular origin. So based on, looking at the pathology of the tumor itself, even within the category of medulloblastoma, we can get a better sense of their prognosis. So I'm going to compare medulloblastoma and pilocytic astrocytoma a little bit more, just because these, if you're working in this population, these are two tumors that you'll see all the time. They are, while being the most common, they're still, 18 to 20%. There's a lot of other brain tumors that children get, but by far these are the two most common. As I mentioned previously, the peak age of diagnosis for both is age 5. But for medulla, you see this diagnosed more commonly before age 10. Pilocytic astrocytoma, sometimes you can see that diagnosed in the early teen years. For both tumors, we see more males diagnosed than females. And, that's an interesting finding. There's a lot of theories about that, which I'll get into in a minute. But, you'll often see more males than females, and that results in some difficulties with our research because we often have populations that are skewed very male, and it's harder to generalize research to female findings to know how, whether or not females really experience the same sort of late effects. So it's one thing that we, we have to take into account when we're looking at research on these brain tumors. And let me see, I think, actually I took out the next slide. Let me go ahead and talk about, so in terms of males versus females, it's really actually not related to sex hormones. So sometimes, that's the theory that comes up, but what research has shown is that one major factor is a protein called retinoblastoma protein. It's referred to as RB. And this protein is known to reduce cancer risk, and it's also significantly less active in male neurons than in female neurons. Now, this was identified in 2014, so this is pretty new knowledge, but it's giving us more information about why we see more males with brain tumors than females. So I talked about the treatment differences. Survival rates are not super different, but medullas have a slightly less lower survival rates. So this is an image of medulloblastoma. This is the same child, and these are pre and post-op, um, before and after surgical resection. This is an 8-year-old boy, and so you'll see it's a pretty drastic difference when they go in and take that out. But then there is also just kind of a mess left behind. And really, what we found is that surgical resection is not so much a risk factor as the subsequent treatment, so chemo and radiation are really much more devastating than actually going in and removing the tumor itself. This is an image of pilocytic astrocytoma. These are 2 different patients, and this just shows that, again, it's in that same region of the brain. You can see some, mass effect issues, and especially in the one on the left. And these patients are both obviously pre-surgery. So when we're talking about pediatric brain tumors, some prognostic factors include age at diagnosis. So prior to age 3, there's a greater risk for worse survival outcomes and worse late effects neurocognitive outcomes, especially prior to 12 months, but certainly prior to age 3. Tumor location, of course, is another factor if the tumor is in a place where it can be resected or not. Histology, so some tumors are more aggressive than others. Subtyping, as we talked about, can make a difference. For gender, there's mixed findings, and again, that's related somewhat to the fact that we have fewer females to study. But generally, we found that females have higher survival rates in some age groups as opposed to males. And again, there's still evolving research as to why that is. In terms of ethnicity, we talked about African Americans and Hispanics, in particular, having lower cure rates. And we talked about before, some factors regarding access to care that may contribute to that. But it's still not fully understood why some ethnic groups have lower survival rates. Metastatic disease obviously is another factor. If the tumor has, become invasive in other parts of the brain or other areas of the body, that is a worse risk factor. Genetic factors, here I'm talking about actually differences in response to treatment. So we found that certain genes respond better to, or indicate that the body will respond better to chemo than other types of genes. And I won't get into too much detail about that. That's sort of a talk all in itself. And then response to treatment is the last prognostic factor that's important to know about. So typically remission should be achieved within about 1 or 2 weeks. And that means that there's essentially just a substantial decrease in the signs and symptoms, blood counts, things like that. And many people are surprised to hear that 1 to 2 weeks sounds very fast, but typically that is what you want to see. And there's a better prognosis for survival if that is achieved. So some potential treatment complications that are important to know about just because of how they relate to the testing that we do as neuropsychologists. So first, you'll want to, if you're seeing a child with a brain tumor or post-brain tumor, you want to know, did they go through a normal treatment protocol or did their treatment protocol have to be modified in some way? So if they have allergic reactions to certain drugs, they may need to modify the protocol. So you may have a pretty standard protocol for medulloblastoma, but there may be some deviations from that if there was an allergic reaction. So you just want to not assume that every kid you see with medulloblastoma got the same chemo. Infections almost always require hospitalization. Obviously, these kids are immunocompromised. And the important thing to be aware of there is that obviously when a child is hospitalized, there's disruption to schooling and educational instruction. So, it's important to know, to get a sense of from the team or from the patient's chart, to get a sense of, how often were they hospitalized, how much did that disrupt their educational experience. Neurotoxicity events also can occur, especially with relation to vincristine, which is a chemo drug that often results in peripheral neuropathy. And then methotrexate, which is in terms of our chemo agents, it's pretty much the number one worst offender in terms of CNS effects. So it can result in leukoencephalopathy. You can have acute methotrexate toxicity. So you want to look at the chart for any events like that in the patient's history. There are paraneoplastic syndromes, which are sort of secondary medical issues that result from hormonal and immune system changes that you see in cancer. And those can be endocrine, hematological, neurological. I won't get into a lot of detail on those, but certainly if you see, some paraneoplastic syndrome in the patient's history, that can have significant implications for what we look at in terms of their neuropsychological outcomes, especially the neurological complications. So I mentioned, while hospitalized, school can be disrupted, and you'll want to interview the patient to kind of find out, to what extent did they still stay engaged in school? So was work sent home? Were they actually doing the work? You'll often see that it's reported that they get school services at the home. So something like homebound services. And that's regulated by state law. So in Texas, I have Dallas ISD listed here as an example. First of all, you have to be out for 4 weeks. And then in terms of regulations, there aren't actually very many beyond that in Texas. So the teacher may come for an hour a day, an hour every other day. And you really want to interview the patient and the family to get more information about how often was homebound instruction actually taking place. And be familiar too with your state law about homebound instruction. And then Section 504 and IEP, many of you may be familiar with these terms, but essentially we're looking at the degree to which a child has accommodations and modifications in school. Section 504 is more accommodation focused, and IEPs include modifications to the actual curriculum. So getting more information about that, and also, not only to know their history, but also to know, is the parent aware of this? Do we need to educate on their options in terms of school supports? All right, so I'm going to jump into neurocognitive late effects of pediatric brain tumors. So as I mentioned, there's typically not many significant effects related to surgical resection itself. So some exceptions to that, one is cerebellar mutism. So this also is referred to as posterior fossa syndrome. And essentially it is a period of mutism following surgery for a tumor in the cerebellar region. And you see this for a number of reasons. Sometimes it's random. If the cerebellar vermis is affected, it tends to be more common. That's the vermis is basically the area connecting the two lobes of the cerebellum. And the incidence ranges widely, in terms of studies reporting how frequent this is. Ranges from about 8% to about 39%. It's very rare, but it does happen, essentially. So the syndrome itself, in addition to mutism, can also be associated with ataxia, hypotonia, irritability, basically emotional issues, motor issues, and mutism. And most kids resolve pretty quickly, within a couple weeks at most. But we sometimes see kids who, even a year after surgery, are still having issues with ataxia and may not have total mutism, but may have some speech issues as well that are lingering. So that's an important, factor to know in terms of your patient's medical history. Other surgical resection factors, we see worse outcomes, obviously, with multiple surgeries and with subtotal resection. Multiple surgeries and subtotal resection both typically just mean that it's a more invasive tumor. It's harder to get all of it. It may be in a very difficult region of the brain. So it's not so much, again, the act of going in and doing surgery, but it's more that's a measure of something else about the tumor that makes it more likely to have negative effects on the brain. So many, as we talk about mass effect, many of our patients with brain tumors also present with hydrocephalus. As you all may know, hydrocephalus is commonly associated with processing speed and attention deficits. And in these kids, that can linger even after hydrocephalus is resolved. One thing to look at in a patient's medical history is shunt surgery. And we see typically worse neurocognitive outcomes associated with multiple shunt surgeries and with complications like shunt infections. So that's another thing to look at. And again, the factor here is not so much the surgeries, but the fact that if a shunt's not working, it means that something's being blocked. There's things changing in the brain. There may be increased hydrocephalus. So there may be other factors essentially that that are pointing to worse outcomes that then shunt surgery is a marker for. Okay. So in terms of chemo, we have some, we've talked about cisplatin and vincristine, or I'm sorry, we talked about vincristine, we didn't talk about cisplatin. Cisplatin is a platinum-based chemotherapy agent that is commonly associated with auditory hearing loss issues, typically high-frequency hearing loss. Not always, but it is a risk factor for that. And then vincristine, we talked about that being a risk factor for peripheral neuropathy, and then as a result, fine motor deficits. So triples refers to intrathecal, which means injected into the spinal cord. So triples is intrathecal methotrexate, intrathecal hydrocortisone, and intrathecal cytarabine. And so if you see triples in the chart, or you may see them listed out separately, those are definitely together a major risk factor for processing speed deficits and attention problems and executive dysfunction. If we see intrathecal methotrexate alone, it actually sometimes is associated with worse processing speed than triples. There was a study that looked at this and found that there may be some protective factor of the other agents, especially the hydrocortisone steroid. That research is still, they're still kind of digging into what exactly explains that. But to know that if you see a history of intrathecal methotrexate, that's certainly a red flag for potential issues with processing speed, attention, and EF. Late effects related to radiation, we see progressive declines in a number of areas. And I put declines in quotation marks because it's not necessarily a decline so much as it is that they are not developing along the expected growth curve. So you see that they gradually, their trajectory of development kind of gradually falls more and more behind their peers. So you see these declines, and that can kind of scare parents unless you explain to them, the score being lower doesn't mean that your child has lost IQ or lost, academic skills. More so it means that they're not really meeting those developmental expectations. So risk factors for worse late effects related to radiation include younger age at diagnosis and treatment, the extent of radiation, so partial radiation versus whole brain radiation, and then the dose of radiation as well. And this is one area where our research has really developed a lot of advances in terms of minimizing the dose, maximizing survival while minimizing cognitive late effects is essentially the goal. So things like proton radiation have been developed within the last 10, 20 years and tend to be more targeted and have less kind of a peripheral spread of damage than some of our older radiation techniques. So when we talk about underlying mechanisms for damage, so certainly surgical resection, there can be some degree of physical damage to the neuronal connections, but if you look at the mechanisms of other factors involved in brain tumors, you'll see kind of why they're so much more relevant than surgical resection, because these are factors that often affect the brain in a larger, more systemic way. So hydrocephalus, as you know, if you've studied hydrocephalus, we see interruption of synaptic connections, which can change dendritic structure. interruption of blood flow, and we see hypoxia and ischemia related to that. And essentially all this together results in subcortical white matter damage, which of course associates with processing speed, attention, those sorts of functions. And radiation, the effects of that. So in the first 1 to 6 months after radiation, you primarily see some demyelination. And then after 6 months, you still see progressive damage. So you see increasing vascular damage, demyelination, areas of gliosis, and broad white matter necrosis. So, so certainly radiation, in terms of when you're doing an evaluation, you want to kind of keep in mind what's their time frame post radiation, and if it's in that first 1 to 6 months, you may see, not as much in terms of late effects as you might see 6 months and beyond. Chemo is a very complicated process, obviously. There are many mechanisms by which chemo can affect the brain. It is essentially injecting poison into the body. So, it can damage the blood-brain barrier. You could see DNA damage, neurotoxicity related to inflammation. It can mess with the endocrine system. There's just a lot of ways in which chemo can affect the brain that we don't always think about when a kid's taking oral chemo, for example. And certainly oral chemo is less of a direct risk to the brain than intrathecal, which is injected into the spinal cord and then circulates through the CNS. But both forms can have implications for neurocognitive late effects. And you'll see some genetic variations in terms of, again, how certain chemotherapy agents affect certain children based on everything from, their genes for DNA repair, their rate of telomere shortening, genetic factors driving neuronal repair. There's many, many factors that we honestly still need to research and learn more about, and we're learning more about every day. So rather than going into preliminary data, I'll just tell you that this is kind of an area of developing research, and we're hoping to understand more about what genetic factors make certain kids more at risk for neurocognitive outcomes, as opposed to some other kids who get the same treatment but really end up doing much better. All right, so I think I have time to talk a little bit about some research that we've done in terms of neurocognitive outcomes of brain tumors. So I'll talk first about basically medulloblastoma academic performance. We know that based on research looking at kind of real world functioning, we know that the majority of them require long-term special ed services and tend to be less likely to finish high school than their peers. Based on that knowledge, you would think that their academic skills would be sort of tanked. However, we found that multiple studies have shown that they actually have average academic skill development. So those studies are just a few examples of, the research really not matching the reality. And so, we took this at Children's and kind of took an approach looking at, okay, what else could explain this? And we know that processing speed is a major risk factor for these kids, a high risk of being a deficit for these kids. So based on that, we added what no one had really looked at before. We added into our study of academic skills, we added measures of academic fluency. And sure enough, that's where you saw the major discrepancy. If you look at that table 4, you'll see that fluency in both reading and math was significantly different and significantly worse than the basic skill development. So essentially saying that these kids have reasonably developed skills, broadly average for both reading and math, but their fluency, so their rate at which they're able to put out the information and finish tests on time, for example, is what's really holding them back and causing them to have a lot of trouble. So we were kind of excited to identify that. It wasn't anything we didn't expect to find, I would say, but it was good to actually kind of quantify that, like quantify there is a reason for the real world struggles that we're seeing. And this kind of relates back to what we see in terms of the neurobiology of brain tumors and late effects. Then going beyond neurobiology, another thing we've looked at is, what influence these kids' ability to do well in terms of academic performance, because certainly many struggle, but not all do. Even though many who don't struggle still have deficits and still, are kind of having to fight against an uphill battle in terms of late effects of their brain tumor. And so one thing we looked at academic fluency. So taking that, what we knew about academic fluency being an area of weakness for these kids. And we wanted to see if an external incentive would improve their performance. And what we found is that actually, regardless of the processing speed deficits that they showed, they did do better under a highly motivating condition, as opposed to the randomized group that did not receive the motivation. And, there's more details about the study that I don't quite have time to go into here, but the big takeaway is, so first, it showed that it showed the importance of looking at factors other than the scores that we generally produce in any neuropsych evaluation. So, beyond looking at processing speed and academic skills and working memory and executive functioning, it's important to consider other factors for these kids. And doing a comprehensive neuropsychological evaluation means taking into account things like personality, motivation, intrinsic motivation. And the interesting thing about what this showed, is that essentially these kids were able to improve their performance in a domain where we see a definite deficit. They still had processing speed deficits, they still had fluency deficits, yet they were still able to improve somewhat within a motivating condition. And so that certainly speaks to, factors that have to be considered in terms of, what is this kid as an individual? What are their intrinsic motivations, work ethic, things like that. And those are important things to talk about with families who may see, you may see fairly disappointing scores, but in the context of a child's personality, a child's, sort of hardworking nature, those can be mitigated to some extent. So again, this is the chart that shows essentially our no incentive group versus the incentive group. The bar on math fluency is oddly vanished because there's absolutely no change in the mean, which was just a fluke. But so you see that there's a significant improvement in both reading and math fluency under a motivating condition. Again, while it was still a deficit, so that shows that it's a true deficit, it also points to the importance of providing accommodations for these kids. And then, in terms of later, follow-up studies that I think we'd like to do would be look at considering motivation in the design of academic supports and services for these kids. The big takeaway picture here is that neuropsych testing, even under optimal conditions, may not reflect optimal performance. And that's something that we all, inherently know, but I think this study did a nice job of illustrating that and is important to keep in mind, certainly when working with brain tumor patients, but also with other populations. So with that, I think we have about 14 minutes wiggle room here for questions. So happy to take any questions.
Thank you so much, Dr. Holland. We do have a few questions. So the first question is, to what degree is anesthesia related to long-term neurocognitive outcomes?
That's a great question. That's actually one I get from a lot of parents, especially parents who are thinking about, not necessarily even brain tumors, but optional surgeries and things, putting their kids under. It's a concern. The issue is that we often, especially in brain tumors, we often don't have a good control group for that. It's hard to, I don't know if there's any studies that have just allowed children to go under anesthesia for no indicated reason. So that said, we know in elderly populations, we can see, delirium and things like that. So we know that anesthesia has the potential to affect cognitive functioning. In pediatric populations, and especially in brain tumor populations, we're not totally sure to what extent that's a factor.
All right. Next question. Is there an age, for example, in later adolescence versus young childhood? Is there an age at which long-term developmental effects may not be as pronounced as they are for children that are younger with similar types of cancer, I assume?
Mm. So that's a great question. So actually, the term that I was using, late effects, is basically the term that we kind of use in the oncology world and other worlds to talk about neurocognitive issues that develop sort of down the road. So oftentimes, actually, what we see is that it may be somewhat counterintuitive, but we sometimes see worse effects further out from treatment. The reason for that being that a lot of these kids are diagnosed at a very early age, and they're treated at a very, very early age. And we don't expect as much of a 5-year-old as we do of an 18-year-old. And so as expectations increase, it more becomes evident in terms of what deficits they have. Um, Certainly we can see, significant effects in 5-year-olds. But on the whole, the pattern tends to be more that they start out more or less on track. They may have some acute deficits here and there, but then as they get older, you get a better picture, a fuller picture of the extent to which that may have affected their brain.
Okay, thank you. That's helpful. Next question. Given that survival rates have improved, are there any longitudinal studies following children as they continue to develop over time in remission?
Yes, that's a great question. There definitely are. And this kind of relates back to the question I just answered. But in terms of long-term follow-up, we do see again just an increasing evidence because we're testing more functions and we have higher expectations. And also, I wish I could draw for you guys, but if you think about an axis, like an XY axis, and think about developmental chart, like say that you've got a line going out from that axis, to steady upward angle, and say that's normal development. And then say you've got a brain tumor patient survivor who may have been on that same track, along that same line. But then they go through the brain tumor treatment process and their line gets sort of offset. So they continue to develop. That line still keeps going up, but it's going up at a less sharp rate. So if you draw that out kind of visually in your mind, at first the difference is not that big. It's just a small gap between the two lines. But as those lines go further and further out, you see that gap widen. And so that's what we see in a lot of these longitudinal studies is that they do, again, show that sort of decline in quotes because it's not really a decline, but they're not doing as well the further out they get.
Gotcha. Similarly related to outcomes, one person asked, are there academic results or the academic results you mentioned, like being less likely to finish high school, perhaps due to parental effects? So for example, having a child with special needs, having the parent having a hard time stepping out of a caregiver role, or what extent do parental effects have on these outcomes?
So that's a great question because we know in pediatric TBI literature that one of the most significant risk factors for worse outcomes is chaos in the home. Sort of, parental emotional distress and things like that. We know in TBI that's been pretty researched. That has not been as researched in pediatric oncology, and it's actually one area that I'm very interested in and I'm actively researching. So I don't have any data for you yet, but I am looking into that, and I do think it's a factor that's important to consider.
Definitely. We'll be on the lookout for those studies. A couple of other questions. So one person asked about your study you presented at the end with motivation, and they were curious what the motivation or incentive was that was used in the study.
Yeah, so we considered a number of different incentives and, whether or not I don't know if this is counterintuitive or not, but surprisingly, the research on incentives for kids shows that money is actually the strongest incentive. And you wouldn't think that a 5-year-old would really care, um, but it's pretty consistently shown to be the most effective. So we told them, for the kids that were randomized to the incentive group, we told them that for every 10 questions they got right, they would get $1. Now, ultimately, all patients got the same gift card amount, but that was just the way we structured the incentive, and you could see their eyes light up. So it was definitely motivating.
Yes, certainly money is a good motivator. All right, last question for today. Are there similar brain reorganization mechanisms in pediatric tumor patients as seen in adults that may help with rehabilitation?
Yes, definitely another great question. So one thing that we see, certainly the brain can reorganize in fascinating ways. And, given that these kids often are diagnosed at a very young age, they do have the potential to reorganize functions. We know especially that the brain reorganizes to prioritize language. So you'll often see, like, if there's a tumor in the left side of the brain, you'll see language pop over to the right side of the brain. Of course, that does mean that other functions are crowded out. Um, yeah, but there is that effect. There is that possibility. I think the caveat to that is that um, some of these kids, especially medulloblastoma, get whole brain radiation. So it's not just the one area that's affected and then the rest of the brain can kind of compensate. It's that you've got an area that's pretty severely affected, and then the rest of the brain is also taking a hit. And so it's not, I think, as it depends child to child too. This is not it's hard to generalize, but you do see that the rest of the brain just kind of struggles a little bit more than you would see in sort of a focal, isolated injury.
I just have one quick follow-up to that. Is there an age gradient for that? Is it more possible in younger kids versus older kids for reorganization to happen?
So you would think so, but actually what we see, and I referenced this briefly, I don't think I specifically touched on that question, but what we see is that treatment before 3 years of age is actually more devastating, both in terms of survival and in terms of neurocognitive outcomes. And I would even personally just, you know, I think there's been research showing that age 5 is kind of the cutoff. More of the research now shows age 3 is cut off, but personally, in my clinical observations, I would say, if I see a kid who was diagnosed and treated before age 5, that to me is kind of a red flag for likely worse outcomes.
Okay, thank you for indulging me that question.
Of course.
Thank you so much. We don't have any more questions for today, but that was a really lovely presentation, very thorough. And I know I'm going to have to go back and rewatch and pick up on some of the extra gems in there. So thank you so much for joining us today.
Well, happy to help. Happy to be part of this. Thanks, guys.
All right, thanks. Bye, everyone.